Thank you very much. Today we're going to talk about access to oral health care for residents in public housing. We thought that this was a great venue because we also wanted to reach out to all of you and talk about what NNOHA was. We're the National Network for Oral Health Access because we work with community health centers all around the country with oral health programs and those who want to have oral health programs. So who are we and what do we do? Well, NNOHA is a nationwide network of safety net providers and their supporters. We started in 1991 by a group of dental directors from FQHCs who recognized that there was a greater need out there for peer-to-peer networking. There was a need for services, a collaboration to most effectively operate health center operations. And dental, we realized, was kind of left out of the communication loop many times. So what is NNOHA? So what we say is really we have a really simple sort of mission. We just want to improve the oral health for underserved populations and contribute to the overall health through leadership, advocacy, and support to oral health providers and safety net systems. Currently, we have about 2,400 members. And those members, we're going to talk a little bit about member benefits and stuff, but those members are nonprofit clinics that provide high-quality healthcare services to underserved, low-income individuals with little or no health insurance, or no insurance at all. So in 2011, what we found was that 862 out of 1,128 health centers across the country offered dental services, 76%. Now, while that might seem like a lot, we still think there's room for improvement. Health centers provided dental care to 4 million patients. At the same time, health centers provided medical care to about 17 million patients. So only 23% of the medical patients were actually being offered were able to access dental care or chose to offer access dental care. So the medical capacity exceeds the dental capacity in health centers. What we know from UDS reports is that in 2011, this is the National Public Housing data. I don't know if all of you guys are aware of this, but there were 61 grantees, public housing grantees, who received grants to provide health care on their site. They served 187,000 total patients. Now remember that number back here, 4 million patients. So it feels like there's a little bit of room for improvement and collaboration. So in those patients, in those total patients, 69,000 patients were under 19, so that's 37%. 109,000 patients were 19 to 64, that's 58%. And 9,300 patients were 65 and older. There was only 43,000 dental patients with 110,000 visits. So again, go back to the number before. So we really are here today to talk about how do we help you increase that capacity. 32.3% of patients were best served in a language other than English. So we know that the old way of, and we've been hearing about it for the last 2 days, the old way that people thought of serving patients doesn't really, there needs to be some adjustments in that thought process. So what are some of the access challenges for residents of public housing? Why aren't they getting to the health centers? Why are they not accessing services? Well, many times they have those transportation difficulties, language difficulties, system navigation difficulties, which it sounds like I've been so invigorated. I was here all day yesterday, and I was so invigorated when I was hearing all the different things that we're doing to overcome these sorts of barriers. There's additional navigation, there are language lines, there's all sorts of different opportunities for people who speak other than English or Spanish to access information in other languages. System navigation, we're really taking a look. HRSA this morning was sharing that we have all sorts of patient navigation grants. Well, those are, and we also have outreach and education grants. Those grants, as far as I hear when I go to different meetings, those are actually, some people are using those opportunities to actually provide different system navigation elements to their patients. Public housing, what we know is that public housing residents were more than twice as likely as other city residents not to have had a preventive dental visit in the past 2 years. And we don't know why that is. We can talk about why that is. We can hypothesize about that. We have anecdotal evidence of what people tell us, but we really don't know what the reasons are behind that. The anecdotal evidence says that because they're in public housing, they have lots of other issues that are maybe going on in their lives that they need to attend to. So as we know, many times oral health kind of drops down on the priority list. So how do we get oral health to go back up on the priority list? Some of the other challenges that they face are lack of insurance. So what are some of the options that they have? They have Medicare, which, okay, we all know, it only covers a very narrowly defined set of services. Medicaid, most states don't cover routine dental care for adults. How many of you live in a state where Medicaid for adults covers dental? None of you. So at NNOHA, what I can tell you is that is one of our advocacy efforts right now, is talking to different state legislators, talking to the federal legislators, talking to them about the need for that expansion of Medicaid to include dental coverage. Because as we can see in this pie, look at what this looks like. If the 51% is Medicaid as the principal third-party medical insurance source, then a lot of our adults are not going to be using that source. So we've come up with a few access strategies, just four, because we thought we didn't want to, we have this litany of this whole list of things that we would love to be able to do. But frankly, it's really the most simple thing. We know that what we're going to have to do, we heard this morning that there's some additional funding coming around for adding new dental programs. There's some capacity building grants. If you have, we would like to just encourage public housing that if you are accessing services, and you're going to hear about a couple of situations where they are working with public housing organizations so that they can provide services. But I heard yesterday that in Chicago they have a health center right on site in the middle of a public housing area. Well, I was just so thrilled by that. I thought, wow, if transportation is such an issue, how about we stick it in the middle of the neighborhood and then you can walk there? You don't have to rely on public transportation. Because I can tell you, public transportation, even though they may have it, may not be accessible, or it may take 3 to 4 hours just to get to one appointment. If you're trying to keep a job, that's kind of hard to take a whole day off for one dental appointment. So we're encouraging people to add a dental program, to really take the opportunity to build their own capacity, to expand their dental programs. If you have, I keep hearing stories around the country of we don't have a dental program, but we have a small community group that is helping us with it. Well, how about we look at collaborative efforts to build those small community groups up into something larger and allow you to expand your program and work with them. Look at your local and state resources. We have all sorts of local resources that are available out there. We have all sorts of people who are really wanting to partner. All we have to do is ask. When we heard about Chicago yesterday, I loved the fact that it was such a collaborative approach. They talked through about how they went out and got stakeholders, resident stakeholders, community stakeholders. They really built a group of folks that had a very vested interest. They really started to talk to who it mattered to, who were those who were providing services, those who were accessing services, and those who needed services. So they developed a group. They developed their own resources. It's surprising when we come together as a group, a collaborative, or a consortium, or whatever, a coalition, or whatever you would like to call yourselves, and start talking to the business community. And even your private dentists who run their own 1 and 2 operatory, or 5 or 6 or 8 operatories, they know the need is out there. They're having to tell people that they have very large oral health bills and losing some patients who say that they can't afford to pay for that. And then they go without care and they see them 2 or 3 years later and they have even more to do, and that person still can't afford that. So once you start to talk with those, I'd like to share just one little model at this time about, I used to work, before I came to NNOHA, I actually worked with a dental access program where we did exactly that. In northern Colorado, we worked with our local health district, which was an FQHC lookalike. I was just a little women's resource center who had a bunch of women. I had 300 to 500 women who came through me each year. And I went out and got business owners to help me support the women. And then I went out and hit all my private dentists and said, okay, so can you take on, how many people can you take on to help me out with? And if these women are coming to me, and what I found was as they spiraled into poverty in my community, they gave up their oral health care. Then they started to give up their women's care. So pretty soon we had women's reproductive issues because they weren't going in for their annuals. And then when they hit 40, they weren't going in for their mammograms or their breast checks at all through this whole period. So then what I saw was I had this, I know this is weird to connect this to oral health, but it spiked into their women's health issues. And I had cervical cancer issues going on. I had HPV issues that were going on. I was a spike in Larimer County for breast cancer. And I thought, well, this is so strange. We have all these lovely funders like Susan G. Komen for the Cure and Avon Foundation who are willing to do these free mammograms. But what I didn't have was a connector source to make all that happen. So then I thought, well, if they're spiraling into poverty and giving up their oral health, which was a critical need for employment and to get them out of pain and stuff, perhaps I could do the same thing. I started doing it on the breast and women's reproductive front, and then we decided that we could do this on the oral health front too. So we started talking to private dentists. We started talking to our local health centers. And everybody came together. The health centers and the dental society came together as those collaborative partners and started talking about how do we create a solution for this. And together they created something called Dental Connections that's completely funded by the community through grants, through foundational grants, through individual grants, through company donations. Our county came in with some money. Our city came in with some money. Our United Way came in with some money. And lo and behold, we started to take off some of the weight that was coming into the community health center, and the community health center was then getting qualified people who then had payer sources, because we then became a payer source. We could actually pay for some of that care. And with their sliding scale fee, we could help offset the cost of that care. We then were using our local dentists in the community to do additional care. So it was this really beautiful marriage between our community health centers and our private dentists, which they never thought that they could ever come to an agreement about before. And that's the same kind of thing that I heard yesterday. I heard that all these collaborative partners came together. We did that not only on the oral health front, but we did it on the breast and women's reproductive health front as well. We had two consortiums that were going on at the same time and developing very similar models. So when I talk about local and state resources, it doesn't have to just be the government. So when you're talking to your collaborative partners at your community health centers, look at outside of your traditional partners and start to talk to other folks in your community who have a vested interest. There's interprofessional oral health competencies that you can work on together. And then there's some workforce innovation. There's things that are going on. We heard yesterday about telehealth. I went home and I thought, oh my gosh, this is what's happening in teledentistry that you and I keep hearing about. There's all sorts of workforce innovations that are going on. There's interesting things happening. Innovations for me on workforce also include National Health Service Corps. What National Health Service Corps is doing is phenomenal. They have lots and lots of people that are going into the workforce. We can put them to good use. We have, in certain states, we've got expanded function people. We've got scopes of services being re-looked at in our oral health clinics so that we can provide additional care. We're looking at different sources to locations and access points. People are extending their capacity through school-based health centers. They're extending it through mobile programs, like I heard about a couple of them yesterday. So I consider all those things workforce innovation. Now, I wanted to include a couple resources for people who, if you are wanting to do this or know of someone starting a dental program, how do we start a dental clinic? So under our NNOHA.org website, you will find all sorts of wonderful resources. Practice management is what we call it at our place for non-oral health folk. But under practice management, you can see Start Clinic. It's that simple. You can go there and you can start to look through all of our different things that we have. We have a manual that if you've got a clinic that is struggling a little bit, you can send your dental director to us for additional assistance. They can become a member. We have all sorts of resources that, by the way, were funded by some very generous funders, like HRSA, who helped us develop some chapters to our operations manual. They start out with the very fundamentals of operating an oral health operation. They go through financials. They go through risk management. In the past year or so, we have developed a much more robust learning curriculum for people who are looking to engage at a little higher level or to increase their own capacity. So what we've done is we've got mentoring opportunities for people if they would like to talk to someone in the trenches who is doing a lot more work in this area or maybe 2 steps ahead of them in the learning curve. We also have the opportunity of the National Oral Health Learning Institute, which was just launched this past year. And in that, we actually connect people one-on-one with a mentor, but we then have worked with the University of Pacific and some of our lovely faculty, of which Alan Patterson is one of them, who have helped us develop a curriculum that is based on our operations manual, but goes a little bit deeper. We have learning modules that they engage in about every other month. They have additional webinars that they engage in. They have projects that they work on. And it's for those more tactile learners who need a little bit more engagement. There's lots of people we know, everybody's a different learner. We have lots of folks who, you know those people that they get a book, they read it, they make their notes in the margin, and they use it like a Bible from there on. And those are those people who don't, they really are so self-learners. Then we have some additional people who just need a little bit more. They may need a mentor. They may need someone to guide their course in their learning. That's why we have mentors. That's why we do additional webinars for added education. And then we have those people who they just don't know where to start. They need someone to sort of help, that. And that's why we started the Learning Institute, because we really felt like that really helps them do that. There's a safety net dental clinic manual. You can actually just look it up, dental clinic manual. Yeah. So for me, I'm just in northern Colorado. So I'm in Fort Collins. Yeah. Uh-huh. Yeah. So what I would say to that is, I don't know about Denver, but I can tell you what worked for us, because we were running into the same problem in Fort Collins. Health district, I'll tell you, health district was not taking patients. They did a call-in day where they would say, okay, you can call in on the first day of every single month. Well, then they got so many calls that they decided to change that call-in day without telling anyone to the 8th of the month. And then if it was a weekend, then it would be that Monday, and it was sort of this shell game. So people who had been calling in for 18 months without an appointment, they never knew when they were supposed to call in. Then it was just this frantic craziness. So I can share with you that it made us crazy, because we were trying to use our local community health center as one of our access points when I ran the initial dental access program. So that's really what came about, was we actually sat down with their leadership and said, this does not work. How do we do this differently? And we talked about how we collaboratively can make a difference in our community. We helped them find some additional funding. So who do you work for? You're at public housing here? Okay, so I would say you guys are quite a large organization. I would sit down leadership to leadership with you, sharing your stories and concerns, coming together and saying, I want to create a solution. What does this look like? How do we do this? Yeah. Mm-hmm. Perfect. Okay, that would be great. Yeah, because I really think that we saw yesterday that you have to train the front desk staff. Well, the front desk staff is so inundated with so much need that they only know what they know. So until we start to share that there is all this bigger story that needs to be attended to, and it may be that our access point is just at such overflowing that we need to talk to them about different ways that we can at NNOHA perhaps help them with some different strategies so that they can serve more people. Yeah. So perhaps we can talk to them about some different strategies on scheduling that might be helpful.
one position for every 40,000 or so. In 2004, when we started our dental program, there was only one dentist for every 45,000. So here you have from 1969 to 2004, the situation for dental in our community was worse even than the situation was for medical in the 60s. And that's not unusual. There is a huge capacity issue for dental nationwide. One of the best things that you can possibly do is to go ahead and start collaborating with the FQHCs in your area. There's 2 or 3 of them in your area. You're with the housing authority. One of the things that you have 2 very valuable things to any FQHC. 2 very valuable things. One of them is you have space. Place for you to have portable dental. So you've got into the unit, which I'm sure you do. You can buy that space for them to put in portable chairs, portable equipment. That's actually the second least of the 2 valuable assets. The most valuable asset that you will have is patients. In particular, you have Medicaid patients. Medicaid patients are gold in FQHC. That's how we pay our bills. FQHC, with a good, strong portion of Medicaid patients, will be a good, strong, financially healthy operation of FQHC. Dental, the trick for our state, I think, Colorado, is to make sure that you're having Medicaid eligibles that are under age 20. That's all that's covered. So typically, in our environment, it's true. You have a lot of kiddos under age 20, I should say, in your public housing. It's a pretty good bet that a whole lot of them are not getting care. So the more of those patients you can provide to that FQHC, the more likely they are able to go ahead and reach out and see some of your patients that can't afford to pay much. I can tell you our first FQHC dental clinic that we opened in 2004 was total, it was 11,200 square foot facility, half of which was dental. It's within sight. I mean, you can take a baseball and throw it and hit public housing complex. And it is the kiddos of that public housing complex, South Jersey, public housing. It's the kiddos of that particular complex that made our dental operations, the 10-chair dental, very first financially viable. I kid you not. Since that time, we've been able to take the essentially profits we make off of these Medicaid kiddos, parlay that into providing the doctor kids health benefit of it. But it takes the public health and the public housing for to be able to work with your kids. Mm-hmm. Supervised by dentists. They're hungry. These are supervised dentists. They know it. They're looking for it. So they really want to be able to do that. Strategy. They want to be able to do more comprehensive dentistry. They can do that. There's no cost to us. You guys are providing a space.
so your question was, do any of them have Delta Dental? So are you asking about the Delta Dental low income program that they have available? Yeah, because they do have Delta Dental here in Colorado does have a specific program for low income individuals, and it has of course it has a finite number of people who are able to engage in that, but through the Delta Dental Foundation, I think is where you can find that information. But if you just go to their website, it has a specific area where people can actually get up to $1,000 worth of dental care at a different access point, a private dentist, a different clinic, someplace else, so that perhaps that could give them some access to some of the services that they need. But thank you, Alan. I knew that you were going to share good things today. That's right. So there is also, you said that you're working with older adults, so there is also a basic screening survey at ASTDD that we wanted to share with you. Some of the different resources that you have. So Boston actually has created a senior, I was going to go through just the health centers, of course, the dental and the dental hygiene schools. If you guys haven't, if your public housing has not developed a relationship with your dental school, if you are lucky enough to have one in the area, please reach out to them. If you need one here in Colorado, holler at me later and we'll connect you with some people, because they are really looking for patients as well. They are looking for opportunities to serve, and they have students, just like Alan said, they have high educated, I don't want to say high educated, senior level dental students and residents, so that are available to provide services right there at the university campus. And then local programs, we wanted to share with you the Senior Oral Health Project in Boston Housing Authority. They actually serve low-income seniors residing in the Boston Housing Authority, and we included that there for you as well, because we thought that that was a really great example of how they were able to provide some services and with a very targeted population that was kind of unique. Some local events that you might also look at, talking to, engaging with, depending on your state. There are the Missions of Mercy, which are now currently, I think they're up to 27 states at this point. And here in Colorado, they do it every single year. And they do rotate around. This coming fall, they will be in Greeley, and then next year they're in Brighton. And so if just look up on the, I think it's adcfmom.org project. That's the Mom Project email. If you go to their email, you'll see which states are engaging in that. And they love to collaborate. I've actually had really positive work with them as they are looking for, they actually go into a community and they're talking to people. Now I know that this is, I want to put a precursor on that, a disclaimer on it. This really is, just an urgent care clinic. They're not going to do full restorative work on it one mouth. They are really going to they're going to try their best to take people out of urgent care, out of urgent pain, and any emergent situations that they have going on. So, but if you've got some people in your housing that can't get access to someplace and need to have an extraction, they need some restorative work done, they need some work done pretty quickly, a Mission of Mercy coming to your area might be a ready answer for them. There's also the remote area medical. So RAM is going around and doing similar things on a little bit smaller scale, but they are also providing some services. Now, so the interprofessional competencies, the medical providers can screen, access, and refer. So sometimes if you have a medical provider, we're talking about, if you've got someone who perhaps is a diabetic, who has A1C scores that, just can't get into alignment, that oral health, periodontal disease might be the concern for them. I know I was in a clinic out in Commerce City just recently, and they've actually started having hygienists on the medical floor. And they're talking to the doctors, the PAs, the nurses. They're actually capturing those people. They're capturing a lot of the kids because, again, as Alan said, that's a great payer source with Medicaid. But then they're also capturing some of those adults who are dealing with some chronic, disease management issues. And so we're really talking to them. We're doing a demonstration project that is actually highlighting this in 28 sites around the country with 3 different health centers, that we're teaching the medical staff to actually do these sorts of oral health screenings and assessments, and then doing quick referrals over to the oral health center. So for some of your patients who are dealing with some other chronic diseases, that might be a quicker way to get a referral into that community health center's oral health center site. So you'll see the oral cancer screenings if medical staff is identifying some oral cancer stuff, early childhood carries risk assessments, self-management skills, and they're also even in some states. I was talking to someone last night who said that they were hearing that nurses around the country were starting to apply fluoride in certain states. So yeah, yeah. I heard, yeah, I heard 3. So I heard a statistic. Oh, I hope I don't mess this up. I heard a statistic on Monday and Tuesday in Washington, D.C. I was at the Medicaid conference, and they were saying that 40% of children who are being seen at a community health center have caries. Tusuke. So, yeah, and preventable. Well, what we're hearing is that's why I'm going to go right back to Chicago yesterday. I love the piece of the whole puzzle that it was this comprehensive team approach where we were talking about nutrition as a way, and for us, nutrition is a way to decrease dental caries, prevention tactics. Really, I heard from, I think, Massachusetts now under Medicaid, they now pay for fluoride toothpaste and toothbrushes. So every single child who goes out of a health center, even if they don't have a dental clinic on site, every single child's going out with a toothbrush and fluoride toothpaste and an awareness about oral health. And I just thought, oh, yay. We talk about integration a whole lot at NNOHA, and our dream is to have medical and dental integration for all of the patients that are seen at our community health centers. And so to have medical staff talking about this and then assessing and referring over to the oral health side, what a beautiful thing that is for that family to be able to access those services. So we are working on the national level to try to continue to get those advocacy efforts out there to make sure that Medicaid across the country, each state is covering those sorts of things, and that your medical teams can support you on this. So workforce innovations also include some workforce things like having registered dental hygienists have direct access. So there's a list of states here in Colorado. We have dental hygienists who actually can practice independently. And some of them are Medicaid, they accept Medicaid. So others are that many times what I see and what I hear is that a lot of people who go to a hygienist, they go there because they believe in prevention. They may or may not be able to or think they can afford to go see a dentist, but they go to a hygienist who's able to give them a good assessment. Thank you. I appreciate that. I'm an asthmatic, so I have a little bit of a cough when I travel. So my gravelly voice, I apologize that it's gravelly today. Oh, thank you. I try to, wet it often. But so here in Colorado, what we've seen is that when I've talked to those dental hygienists who have independent practices, they say that they see lots of people who, because their price is a little bit lower, they have, they're able to see patients, they're able to refer to dentists or to community health centers, so it gives you a referral source. And they're very well respected in their communities. They don't do any restorative work. They do preventive work, and then they refer to qualified dentists all around our state, but they help you obtain access. Community health corps, we have the National Health Service Corps. We have community dental access points around the country. We have, I'm most familiar with Colorado and some of the other rural states to our east, that they have community health corps that they actually have groups of people who go into rural communities and provide services, not among the Mission of Mercy, but they go in and they really work with independent groups. And then some of you were in the telehealth thing yesterday, which is an exciting thing with teledentistry. We're hearing great things in rural populations that by using teledentistry, they're actually able to guide people to provide services in places that otherwise don't have any dentists. We hear a lot about dental shortage areas. And what we know about those is that, like, for instance, which seems bizarre to me, Kansas. Kansas has counties where there isn't a dentist. Kansas is in the middle of the country. It's middle of our breadbasket. And yet they have incredible dental shortages, especially among the western side of Kansas. So what we know with teledentistry is that if that tool can be used in more urban areas, that tool can actually be used in places like in western Kansas, in the Dakotas. I was talking to some people from the Dakotas just this week who say, that there's just no access at all. They have no dentists who are willing to live in these very, very small rural areas, but they do have some dental assistants, or they can send a dental assistant out there who through teledentistry can actually provide services. They're having great success up in the Arctic Circle of Alaska. They, through direct access, they have a workforce. They've actually expanded their scopes of services to include what they call an expanded function dental assistant. And actually, that's not their real name. It is, I was going to say, it's a, I'll give it to you. But they have dental assistants who actually can provide some restorative work, but through teledentistry, they're actually using a Skype model, like we would say. They're using a Skype model to actually, the dentist is guiding the assistant the entire way. So they're actually able to do pulpotomies as well as restorative work. So it's providing access to dental services that they've never had before among the tribes who live in the villages in the Arctic Circle. Do you want to talk a little bit more? I know.
Okay, well, North Texas Community Health Center is where I'm at, Chief Financial and Operating Officer. So we have been, we actually started out in 1969, 1970 as a family medicine residency training program, training doctors in the specialty of family medicine. We converted to becoming an FQHC, a federally qualified health center, in 1999. In 2007, we added there's 4 types of community health centers. So there's 1,200 community health centers across this great land. Most all of those are Section 330E, which is just a standard community health center, and that's what we were from 1999 on to 2007. 2007, we added 2 more of the remaining 3 designations for community health centers. We added public housing, primary care, and we added health care for the homeless. So we have 3 of the 4 designations. There's now 64 public housing, primary care grantees in the country. So in the country and in the territories. I think Puerto Rico has a really large presence with the public housing grantees. So we've been doing public housing since 2007. And originally, to be quite frank with you, also we really were doing some public housing. We went into it thinking we were going to do medical care, so we built this incredible clinic. It was like a $1.9 million project. $1.6 million of it was donated money. And I'm here to tell you, of that $1.6 million, the vast majority of it was donated because we were putting in a dental clinic. The dental part sells. You have a lot of private funders, a lot of folks that really have soft hearts for doing something to address dental care. In the beginning for us, it was probably 4 or 5 major funders, each one of which put in a couple of $250,000 to get us up towards that $1.6 million. But what really made it work afterward, I mean, you can make a clinic work. If it's $1.9 million to build a clinic and $1.6 million of it's donated, you're really only having to come up with $300,000. You can generally get a loan or come up with that $300,000 on your own as an organization the size of ours. But the God awful truth is that because we built it so close to a public housing complex, and because we knew that the children in particular of that complex were so underserved, that we knew that we would be doing quite well operationally on the finances. And sure enough, within just a few months, frankly, we were already at full capacity in that half of the clinic. A couple of years later, we added another, I guess it's probably about 3 years later, we added even a larger half to that half, and that site was that half was also up to beyond full capacity as well. So the connection between the financial and operational success of our particular clinics, in particular our oral health clinics, have been tied very directly to being in close proximity and otherwise working with the public housing authority and the residents of those public housing authorities. We do have what's called 2 navigators. There's a program that is sponsored by Annette. It's called the Community Health Corps program. Everybody here heard of the Peace Corps? If you've heard of the Peace Corps, the American version of the Peace Corps, even though Peace Corps is American, it's generally for international efforts. The AmeriCorps program is the same thing, but for United States-based efforts. National Association of Community Health Centers has a program that is an AmeriCorps program. They call it Community Health Corps program. The volunteers, if you will, like the Peace Corps volunteers are called navigators. And we have two of those, actually three right now, stationed at various public housing complexes to not only schedule appointments, but to facilitate getting the patients in to all levels of care, be that medical, oral health, or behavioral health. That's very true. Over 80% of the children living in the public housing complex get their oral health care from Heart of Texas Community Health Support, from us. What's also true is that only 10% of those children were getting any oral health care at all prior to us opening up our oral health program. The challenge is really trying to figure out what we can do to get more access for those kids and for those adults that are living inside the public housing complexes. And I think that we've addressed that challenge in the last 2 years. Again, oral health sells. We've got a major benefactor in our community that was so concerned about adults not being able to have access to oral health care that he is personally funding an endowment for the provision of oral health care services. He puts in $25,000 a month into this fund. And that fund, we get to use it all if we want, and then build up separate endowment monies with the revenues we generate off of that. So it's taken us a little bit of time to be able to build up the system that we have. We're a far cry from being done. We've gone from one dentist for every 45,000 poor people in our community to one dentist for every 10,000 poor people in our community, and that's a lot better. The goal is to get it down to one dentist for every 2,500 to 3,000 poor, vulnerable folks in our community. And finances is typically the issue, and I would submit to you that one of the best things that we did, if not the single best thing that we did, was making sure that we coordinated all of this with the public housing community. No, I don't think so. We don't have enough time for us to go into that. So. Get your microphone. Yeah, so the question is, do we use portable units or are they fixed sites? Right now we have 5 sites, actually 4 sites that have oral health. One site we typically split it up into side A and side B, but 4 sites, but we also have portable chairs that we take. This is another great program. We take those portable chairs and we go to the public housing complexes, we go to the elementary schools. Now, those are wonderful, absolutely wonderful. And I'll tell you who really likes that. I can tell you this from personal experience. My daughters are in their last year of dental school. They did a rotation with us, and they got to go to both the public housing complexes and the elementary school-based clinics. And in the public housing complexes, what they really enjoyed was not doing necessarily as many children. They really enjoyed getting to do a lot of adults. So the students really do flourish in the public housing complex locations.
I also wanted to share with you a site that we saw that our staff got an opportunity, and some of the people who got to go to our National Primary Oral Health Conference last year. We went in San Diego, California. San Ysidro Health Center actually is doing things very similarly to what Alan is doing in Waco. And so they actually have free dental screenings and other medical services at the public housing sites and retail sites where they shop. They've actually gone out into the community. So they really are going out and soliciting people and talking to people. And they created a mobile unit. They're very much like Waco, where Heart of Texas, where they are going out with portable chairs to do assessments and screenings and some work out there. When we went to visit them, they really had sort of a wraparound approach for the whole family, understanding that Medicaid for Children was going to get people into the door, but then also understanding that to take care of that family, that was a critical element for them. So they built their financial model around that, and they actually were able to really serve patients in an innovative way. Part of their way that they did it was their Healthy Steps mobile unit. They actually took it out, and they started out with portable chairs, and then they eventually just got a mobile unit that they were able to track around and provide care, because they weren't as close to some of their public housing as they had thought. They were in a very old area of town. It was very accessible by public transportation, but it didn't have a lot of public housing directly around it. So they felt like they really needed to do some additional steps to bring the services to the patients. The referral average to the dental department went up to 90 per month. And so that was their referral rate from the medical side. As we had talked about before, doing those clinical core competencies and just training each other on how to do stuff, they found that that was a really great thing to do. One of the things that we also got to take a peek at was their prenatal program. And every woman who was coming through prenatal, if she wasn't already a current patient of the dental clinic, she became one. They were doing oral health assessments on every single pregnant woman. So that was a really critical time of a woman's life. It also set the stage for her child's future health and preventive efforts. So I can't say enough about how innovative that was. Yeah, there's lots of pregnant women at a public housing complex, and so they really felt that that was someplace. They even went so far on, as we heard yesterday a little bit, they even went so far as to do cooking clinics and stuff with pregnant women so that they could really set the stage for good nutrition and oral preventive, interventions at a very early age. And they just said, we can stop the spread of type 2 diabetes. We can stop the spread of dental caries if we start educating our moms. So our staff just came away just feeling so thrilled that they really were taking care of the whole mom and the future baby. It is. And for oral health, many times people don't think of your hospital systems. Your hospital systems also understand that correlation between pregnancy and prenatal health and the baby's health and family's health. So, as you're looking at, again, going back to those local resources, talk to your local hospital about this opportunity. Your United Way. There are other funders outside of the federal government who see, they understand the studies. Talk to them about what we have found. There's a direct correlation. We understand this correlation. We want to change the face of our patients, and we really want to take care of them in the best way possible. So use those private funding arms that you may not have thought about before, or you read the restrictions and thought, they don't really fit us so well. Just go in and talk to them. Yep. So in Sand Procedures, what we also saw was what was working was, this is what they really said to us. They were like, what's working for us is having a medical provider at the mobile unit, personally recommending the dental appointment. So is anyone familiar with tobacco cessation efforts? And how, okay, good. So you understand that one of the things that was such a magical thing when I started to become familiar with that was if someone wanted to quit smoking and they wanted to do it on their own, there was a very slim chance that they could do it. If their friend or loved one or wife or children or something gave them a little pressure, a little bit higher. If it was peer-to-peer, smoker-to-smoker, somebody who'd done it before and walked the tread of being a non-smoker and had success, a little bit better. The best outcome came from when their doctor said to them, you need to quit smoking. And so that's that same thing with oral health. We know that when a doctor says to you, you need to get your mouth looked at. We need to do a quick assessment and get you over and do a screening and do an exam and get you over to see a dentist right away. I think it could help with your health. We find that those people become much more compliant patients. And that referral carries weight. It carries great weight for your patients who might be a little bit resistant otherwise. The patient and parent was provided with a dental appointment before leaving the mobile unit. So that kid, and this is what we saw at the clinic that we went to in Commerce City, they were talking to the parent and the child at the immunization. and saying, well, I see that you haven't had a dental appointment in 3 years. We need to get you an appointment right away. So let's just schedule that while you're here, get it on the books, and get you going. Those appointments, they were reporting to us that they had a far less, of course they had great follow-up as well, but they had a far less fallout rate than other ones because the parents heard from the doctor that this was an important thing for them, and it was just one more of those follow-up visits, just like an immunization. Free transportation. Fantasy drove they were doing bus tokens, and they had people that in the community, they had navigators they had promotores who were doing transportation. They had people who were available to help transport. They had kind of a fleet on the ground of people who were willing to step in and help out. And they also found that people didn't like to wait. Okay, I don't like to wait, so do you like to wait? But a short appointment wait time. When they started to see that they had people who were wandering out. This was one of the things that they thought was so interesting. They got them an appointment, they got them there, they did the follow-up, it's all great. But then one of their complaints was, and you made me wait an hour to see the dentist. Well, because the dentist the scheduling wasn't quite perfect. So this was an internal issue that they had to do. They had to really help take a look at a different scheduling pattern for how do we decrease appointment wait time. And that's something that at NNOHA we're able to help you with. We can actually help you with some suggestions. We can connect you with people who can understand your specific issue, and they can help walk you to a different way. I have heard that you guys have employed some different tactics that have worked very well. So the challenges were that belief is oral health is not as important as other health needs, which we combat with having those medical providers talk through that. Sharing with them, just like that tobacco, you need to stop smoking, you need to see a dentist, you need to do this for your own health. And then lack of knowledge about how to navigate the community health center systems and the sliding fee scale. Many people have become they have a great understanding. They've become very knowledgeable about how to navigate Medicaid. They've had their children on Medicaid. They've got parents on Medicare. They get how to navigate this. But then they start talking sliding scales, and this is a whole new language. So understand that this is a new language. This is a new language. It takes a little while to understand the language. So there just is a lack of knowledge about how to navigate the system, how to navigate the sliding scale fee, how to make that work. I always think that if we give them a little bit of knowledge, it's completely power for them, and they can start to understand what that really means. And what I found in my experience is that many people who had been told by a dentist a long time ago that their treatment plan was going to be a $10,000 treatment plan didn't realize that because of their income, they were eligible for a sliding scale fee at their local community health center that brought that down to a much more manageable monthly payment for them, and that they could actually afford that the oral health stuff that they need. That whole treatment plan could be completed over an amount of time, and they could make payments, and it became affordable for the first time in their lives, and they wouldn't have put it off so long if they had had an understanding about that. So this is my contact information. I can connect you with Alan if you would like, and if you would like some additional examples and stuff from him. But please reach out to us. Look at our website. I did leave some time for questions. So do you guys have some questions? Anything? Well, thank you. And for mobile units, we also are connected to some of the suppliers and stuff. There's one group out there, one gentleman actually, who has developed this strategy for how to fund a mobile unit. And he sells mobile units around the country, and he has helped people. He goes in and he says, you want to buy this, and this is how much this is going to cost, and here's how you do it. Because he recognizes that, oral health, dental is expensive. The equipment is expensive. The staff is expensive because they are a very highly qualified staff. The whole thing is an expensive undertaking. And so he has that figured out. And I've heard from 3 different sites now that he has done a great job and they've been able to afford mobile units. So just as an idea, if you're thinking about it, reach out to him. So, oh yeah. And you can, one of the statistics that I have used in my past when I've been talking to business owners about oral health and dental care is the fact that, there are statistics out there that talk about how many children are missing classes every single day because they are in dental pain and they can't focus. They are missing school. Their parents are missing work. It's a business proposition for people that when you start to talk to corporate entities who they know that they're having, people who are not showing up to work and they're using their sick time for oral health issues. And so, they get that. They're business folks. They understand. Yeah. Wonderful. I'll give you my card too. Because we have been able to work with different practices, different dental clinics to help them not have that kind of thing going on. We've really helped them connect with, different strategies of how do we schedule? Why are you on the phone for 3 hours and 2 minutes? That, that isn't working somehow. So how do we make that different? How does that look different? Mm-hmm. Mm-hmm. You're welcome. Yeah, it's a win-win for both. So, okay. Well, thank you so much for coming. You give me a call.